Good morning, my dear friends. Thank you, ISCCM Hyderabad chapter, for giving this opportunity to invite me the Neurocritical Care Section 2023. I would like to discuss a topic regarding the traumatic spine injuries. Polytrauma is an important aspect of any intensive care practice. Neurocritical care is one specialty, even though it is been getting branched out from a general critical care. However, all intensivists sitting in this room, ICU physicians have to come across traumatic brain injuries and other polytrauma patients in our ICU. So it is important that even though more attention will be towards detailed investigations and evaluation of TBIs, blunt injury abdomen requiring laparotomy immediately, and other chest injuries, pneumothoraxes, which needs immediate attention, spinal cord injuries or spine injuries is something which can be overlooked. It's important as an ICU physician where do you stand and what is important in ICU management of traumatic spine injuries. So it's always a spinal cord disease or an injury is a debilitating disease, which can definitely affect functional and, of course, an economical burden to society and the individual. And the sad part is that it occurs predominantly in young, healthy adults, which they can lose their productivity and quality adjusted life years. Both traumatic and non-traumatic etiologies have been present in spinal cord injuries. Estimated mortality in a rough calculation is around 4 to 17%. The right slide shows the common etiologies of this. Your motor vehicle accident comes the predominant number, followed by history of falls, which happens predominantly in elderly. With the brittle bones, they can have more of a spinal cord injury. Sports activities, acts of violence, again, attacks and things can be a common thing, and 9.7% can be other or unknown etiologies. So when a primary injury happens, the primary injury of the spinal cord results from the acute trauma, which is cord compression by the bony fragments, the blood products, the hematoma formation, the soft tissue or foreign objects. It is followed by a vasogenic edema following syncytic event resulting in spinal cord ischemia. This particular thing, when it moves forward, results in cytokine storm and vasoactive proteins and cause inflammation, worsening ischemia, and promoting cell death. And lastly, we have the free radical injury resulting in oxidative damage and excitotoxicity. So when a particular person comes with a history of trauma, subtle symptoms needs attention, which includes if there is a pressure or a swelling in the neck or back, and the patient, if it's conscious, complains of backache, any neurological weakness, subtle loss of sensation or tingling and numbness, along with other injuries, and a twisted neck, breathing. If the breathing pattern is getting affected, probably that is something which is an involvement of the spinal cord. And if they have bladder and bowel control issues, and if they're walking, it's trouble balance speaking, which tells us or which gives us a clue that there's an additional spinal cord injuries. And this is a description of a clinical presentation, which is an Asia American Society of grading spinal injury association scoring and the grading for spinal cord trauma. The complete means there is no preservation of function below the injury, no sacral sparing. Incomplete has got three things. The first one, sensory but not motor function is preserved below the level with sacral sparing. Incomplete has, again, the motor function has two things. One, the motor function is preserved below the level, and more than half the muscles have weighed less than 3. And incomplete, the second, the D means that the motor function is preserved at least more than half the vessels. Normal means the functioning are normal, despite being a spine injury. This is a brief, outlook about the scoring systems is there. Now, when we talk about complete injury, it's an acute setting. The reflexes are absent, including the bulbar cavernous, and sometimes male patients will have priapisms. And the bladder retention and urinary retention, bladder distension are very common. And patients with high thoracic or cervical injuries can have sympathetic dysfunction, which includes bradycardia and hypotension. Incomplete injury is predominantly, we have 3 neurological syndromes, which I think you would have read in neurological textbooks, where the clinical features vary. It is not of an interest of an intensivist perspective. The central cord syndromes are the anterior cord syndrome and Brown circular injury, where we will have ipsilateral and contralateral vision, which is not important right now. When it comes to the management, the emphasis should be again and again on a pre-hospital management, because the treatment of a patient with trauma starts before the patient reaches the hospital. Your EMS, your ambulance staff should be updated, should be informed about the importance of transportation of a polytrauma patient. And the data says that between 3 to 25% of injuries occurs after the initial trauma, either during transportation or early in the course of management if this is not addressed properly. So C-spine stabilization holds the key, even if it is done from the pre-hospital setting or in the emergency room. Once it comes to the ICU, it is an important point of an intensivist to ensure that the C-spine is stabilized. If it is a polytrauma patient, unless there is a appropriate diagnostic testing has been done to eliminate the diagnosis. If the patient is suspected of having a spinal cord injury, conscious or unconscious, you need to put the patient in a cervical, the spine board, or with the head being kept rigid, the tapes are blocks, or with the rigid cervical collar, which is a man J collar or Aspen collar. Always remember that the arms must be secured to the patient's side with spider straps. And once it is in the hospital or in the ICU, it is important that you evaluate removal from the spine board with other things. And it is important that there should be adequate manpower should be there to assist the transfers to prevent a potential injuries while being transportation. And this is a quick review of the indications for spinal restrictions, a patient with altered level of consciousness and evidence of intoxication. If there's a mild neck pain or back pain, if the patient has got a focal neurological signs or symptoms, numbness or motor weakness, any anatomic deformity of the spine, or there's a distracting circumstance of injury, which means a long bone fracture, degloving, crush injuries, even a distracting circumstances like an emotional distress, communication barrier is important so that you maintain the C-spine stabilization because the patients may not be able to communicate properly, and it may not be able to patient's ability to contribute to a reliable examination to avoid to say that C-spine injury is not there. So after settling that, if you have a spinal cord injury, you find the location. If the location is identified, is it stable? And if the stable spine injury is associated with a spinal cord injury is the next question. If there is a spinal cord injury associated with a spinal injury, does this patient requires an urgent or emergent operative intervention is left? If the surgery is not indicated in an emergency basis, you need to optimize the medical care and then subsequently recovery and rehabilitation. Now, ICU management always starts with our ABCs, which includes an airway management, followed which we have this hemodynamic management. The pulmonary issues needs to be addressed, and the long-standing debate about use of steroids in a patient with spinal cord injury, and when to plan for surgery, and what are the supportive care. Airway and breathing. AB stands first in all polytrauma cases, and always assume a C-spine injury in a multi-system trauma if it is, especially if the patient is unconscious and there is an injury above the level of clavicle. You know that you need to plan an intubation with C-spine stabilization, which we normally call it as manual inline stabilization. All of you follows that. Always remember, if there is a C-spine injury or a cervical or a spinal cord injury, especially above C3 to C5 level, or there is a thoracic thoracic root involvement, pulmonary complications are expected because the diaphragm is involved, so you can have a lot of breathing issues, a lot of lung issues, and when there is a thoracic root involvement, you can have the respiratory accessory muscle involvement. So pulmonary complications is bound to happen. Of this, the common is aspiration pneumonias, and most of the patients require invasive ventilation, maybe end up in tracheostomy. However, one important thing in a systematic review is that even though there is an involvement of the diaphragm and the thoracic root, a review found out that almost 25% of the patient could be weaned off from ventilation at the end of 2 months. Why I put this point is that sometimes after the immediate care, after the acute care, you may have to shift the patient on a ventilator support or a BiPAP support. However, attention to all the medical issues and the patient waiting can definitely end up 2 months later. Weaning is possible. Now come to the circulation, which is an important thing. You have two shocks happens in a spinal cord injury. One is a spinal shock, which you all know that immediately following a spinal injury, there's a transient loss of complete spinal cord function below the level of injury, and imaging may not be remarkable. However, spinal shock can occur from a damage to any region of the spinal cord. Whereas a neurogenic shock, which includes the sympathetic dysfunctions which happens with hypertension, hypothermia, bradycardia, this predominantly occurs with cervical and high thoracic about T6 vertebral level. So it is important to distinguish between a spinal shock and a neurogenic shock when it comes to the acute spinal cord injury. This particular diagram depicts, see what is there on the left side is predominantly an injury happens to the cervical cord or the high thoracic cord, which results in what is there on the blue line is a sympathetic tract. There's a decreased sympathetic outflow to the heart and the peripheral vascular tissues. Whereas the parasympathetic and the baroreceptor reflexes are kept intact. So the input from the baroreceptor like carotid and aortic arch is maintained, and the parasympathetic outflow to the heart is also unaffected. This results in an increased parasympathetic activity, which is causing decreased heart rate and the cardiac output. Whereas if you look at the right side diagram, again, even if when there's a spinal cord injury, because of the decreased sympathetic outflow to the vascular system, it's a loss of vascular tone, which results in the decreased muscle tone and which results in increased blood pooling and decreased venous return to the heart, again affecting the hemodynamic instability. The additional point is that when there is a sympathetic parasympathetic mismatch is there, when there's a noxious stimuli happens with regards to bladder or bowel or any pressure sore, this results in high sympathetic outflow, sympathetic responses, resulting in acute hypertensive crisis. And when this happens, the parasympathetic try to overcome the sympathetic by causing vasodilatation, resulting in headache, dizziness, nasal congestions, sinus congestions. So this particular acute hypertensive episode in one side, followed by parasympathetic outflow causing vasodilatation, hypertension, resulting in what is a term called as autonomic dysreflexia, which is very common in all spinal cord injury patients. So the initial phase, hemodynamic management is going to be a challenge in every intensivist. The current guidelines support treatment of hypertension if the BP is less than 90, initially with the fluid, any other trauma patient, and then vasopressors. Which vasopressors? Because of the incidence of bradycardia is there, it is important that you use dopamine, just both sympathetic, chronotropic, and inotropic support, unless the dopamine is contraindicated. And if the dopamine is not going to help you, the second line of agent you always consider using a norepinephrine. Always remember that vasoactive agents which cause significant bradycardia, like phenylephrine, should be avoided if you're suspecting an injury is above T6 level, because the patient may not be able to mount a sympathetic response because of sympathetic tract sympathetic cutoff because of trauma, and response to bradycardia may not be there. So the recommendation from the AANS recommends that a MAP to be maintained is 85 to 90 millimeters of mercury, 7 days post injury. This is a paper which published in Journal of Neurotrauma, which says that which found out about what is the optimal mean arterial pressures whether a mean arterial pressure augmentation correlates with a neurological injury. Found that 85 to 90% if you maintain probably prevents further cord ischemia. That is where the recommendation says that 7 days or 5 to 7 days at least, you maintain a MAP of 85 to 90. Now, if there is no neurological improvement is seen after the 72 hours, probably you can consider cessation of blood pressure augmentation because it may not makes a big difference. Or if there's a complete cord transection, if an MRI has been taken and it's there, then again, giving and augmenting the support may not be of value. What about the imaging? Now, all of us know that you need to image rule out the C-spine injury. And C-spine, Canadian C-spine rules tells that age is more than 65 years, you need to confirm the spine will be a CT or MRI. Nexus criteria which helps us to rule out a spinal cord injury, and these are the 4 or 5 parameters where there is a neurodeficit, where the patient is under influence of ethanol, and extreme distracting injuries like any fractures, and patient is not conscious to give a good history, and there is spinal tenderness, probably these kind of things are there, you need to consider doing an imaging. If it is not there, you can definitely rule out a C-spine injury. And is an MRI indicated? There are certain important things which MRI can give an edge, but MRI is not practically possible. Pediatric patients particularly, it is important to evaluate the cord and compression, you need to do an MRI. In adult patients, if you're suspecting an atlantaxial dislocation, then prognostication is very important to do that. Otherwise, if if it's available in awake symptomatic patient or obtended patient where where the close reduction of a trauma and thing is failed, and if you're doing an MRI for other reasons, probably MRI is indicated. So MRI is not something which is definitely indicated all the time, and this is a recommendation following a systemic review by Bozo et al., where a weak recommendation that MRI is done is a weak recommendation for doing MRI in all patients with acute spinal cord injury. Whereas a strong recommendation is doing an MRI for mainly for prognostication in the acute period. It's also added that you need to do a sagittal T2 MRI sequence in all MRI protocol to predict the neurological response. So 2015 Eastern Association of Surgery of Trauma updated it recommendation level 3 that a negative helical CT is sufficient for clearing C-spine and removing C-collars, and no conclusive evidence to recommend MRI in all patients. CT spine, as all of us do, is enough to do it. The big fat debate is about what to give steroids. Methylprednisolone is suggested to improve neurological outcome in acute non-penetrating traumatic spinal cord injury. The evidence is limited and usually highly debated. 2013 ANS CNS spine section guidelines for acute subacute spinal cord injury management do not recommend methylprednisolone in spinal cord injury. Whereas 2017 AO spine recommendation, which international expert panel systemic review, demonstrated that a modest improvement in motor scores if methylprednisolone is given within 8 hours of injury with no significant improvement in the complications. And all of us are aware of the 3 trials where the NESIS 1, 2, and 3. The NESIS 1 trial used methylprednisolone 100 mg bolus followed by 25 mg every 6 hours for 10 days, or 1000 mg bolus followed by 250 mg 6 hours for 10 days. 6 months, 6 weeks, 1 year, there is no differences. And high dose methylprednisolone, the wound infection rates were very high. This is followed by NESIS 2 trial where initial bolus was given 30 mg per kg followed by 5.1 mg per kg per hour for 23 hours. Naloxone was given the second arm, followed by the infusion, and a placebo. There is no difference in the motor sensory improvement 6 weeks, 6 months, 1 year. But in the post-hoc analysis, they found that methylprednisolone giving within 8 hours of injury, there is an improvement in the motor function. Now, this is followed by the NESIS 3 trial, where they did not use methylprednisolone if the patient presents after 8 hours. In presence within 8 hours, they follow the protocol same like the doses same like the NESIS 2. But the one arm they give for 23 hours, the second arm they give for 48 hours, and third arm they use the tresiloid mesylate compound. And they didn't find any significant difference in the outcome. However, it's a certain to confuse things. They found that if you are treated patients with methylprednisolone within 3 to 8 hours of injury, and given for 48 hours, they found that motor functions have improved. The controversy still continues, and this is a bibliometric analysis of publications of spinal cord injury. And a reasonable conclusion with all the guidelines is that if the patient is present within 8 hours, you can use a 24-hour infusion of methylprednisolone and assess the patient how things are going. This could be a reasonable conclusion. Now, what about surgery? It is important that if the spinal cord injury is there, with FSH, you need to have an early spinal cord decompression and stabilization. However, one thing is important that the cardiopulmonary complications needs to be addressed. Patient has to be stabilized with regards to cardiac and pulmonary status before you plan a surgical procedure, because you need to put the patient on a prone ventilation, prone position, or a side, lateral position, which again emphasizes the role of stability in both cardiac and pulmonary before putting the patient for a surgery. And if there is a coagulation abnormality, please do address to correct it. And this is a particular paper published in 2012, and the recommendation after this particular paper, what we can normally come to conclusion is that urgent decompression within 24 hours to be performed by patient with stable neurological examination, and if the patient has an actively declining neurological symptoms, you need to plan an emergent decompression in patients with acute traumatic spinal cord injury. After initial part is over, intensivist role does not stop over there. It is important that you need to have adequate supportive measures, which includes the feeding. Nutrition has to be started. Early enteral feeding is important. Bowel care, again, I mentioned about the noxious stimuli precipitating the acute hypertensive crisis. So you need to have stool softness on place and ensure that adequate bowel movements are being there. reflex, gastric reflex needs to be addressed because really gastric emptying is another problem. And with patients with complete spinal cord injury, rectal examination should be performed daily because bowel movement is an important aspect because that stimulus can always precipitate a hypertensive crisis. Again, thromboprophylactis, I don't have to emphasize much on that. You need to put the patient on a long-molecule heparin 72 hours post-injury with intermittent pneumatic compression device. A combination of both is important, and Spinal Cord Consortium recommends at least 8 weeks of pharmacological DVT prophylaxis. If you're sending home for a home rehabilitation, 8 weeks you need to continue LMWH, daily subcutaneous injections. I mentioned about autonomic dysreflexia, which is very common. 26 of 28 patients in this particular paper are found to be having an autonomic dysreflexia. What is important is that a proper hemodynamic management and avoidance of noxious stimuli again is important to prevent autonomic dysreflexia in the patient. Again, the treatment also includes removal of tight-fitting garments, correction of, I told about in-sitting stimulus, and if hypertension persists, you need to consider short-acting antihypertensive if the non-pharmacological measures fails. Nifedipine can be an option in our setting. Urinary retention causing hydronephrosis, recurrent UTIs is a common factor, and you need to put a catheter. And always important to mention the catheter care and the strict fluid balance. And catheter can be removed with void trials if required. Spasticity can be a cumbersome symptom which occurs within the later stage, and it can affect the quality of life. Sedentary exercises, personal management, manual stretching can also help. There are other pharmacological methods which includes baclofen, tizanidine, and dantrolene, which is no more of a chronic use. Always make sure that decubitus ulcers is being done because it's going to be huge impact on the patient outcome. You need to use specially redistribution surfaces and mobilize the patient as soon as possible. There are newer therapies which has been seen as riluzole, which has been used in amyotrophic lateral sclerosis, but the Danilus monophosphate one, spinal cord cooling in acute phases, and autologous macrophages. These things does not have much of a definitive evidences, but riluzole is something which has been looked upon in some trials, which can tell us what is the role in acute spinal cord injury. So, my dear friends, to conclude my talk, spinal cord injuries is something which can be overlooked in an acute polytrauma. Intensivists should have a thing to look into it, and spinal cord stabilization is mandatory. Hemodynamic augmentation is important because you need to maintain the pressures. Steroids, I mentioned, probably 24 hours with the patient presence early, and decompression, if neurological worsening, emergent decompression is the key. Supportive care, which includes all the things, aspects, lung support, the infection control, all these things are important for a good outcome. Thank you so much for the patient hearing.